Thank you, Prof. Khanna, my good friends in India, for allowing me to speak briefly at the 13th APVIC meeting this year. So my topic given is balancing bleeding and ischemic risk for the high-risk patient, the APSC consensus statement. My name is Jack Tan, the immediate past president for the Asian Pacific Society of Cardiology. These are some of my conflicts of interest. From 2019 until now, the APSC has developed 10 consensus statements, and I'll emphasize 4 of them in relation to this topic. So what are the antiplatelet options for CCS, ACS, or PAD? Firstly, there's SAPT, cilostazol, oral anticoagulant, DAPT, 2B3A, IV cangrelor, subcutaneous salotogral, or triple therapy. But as we know, if we use more and more potent or combination therapy, the bleeding risk rapidly increases. There are really a lot of antithrombotic targets from VKA interacting in the coagulation cascade to a factor 10A NOAC inhibitors, low molecular weight heparin, unfractionated heparin, bivalvulorutin, and direct thrombin inhibitors orally to target fibrinogen and clot formation, together with aspirin that targets thromboxane A2, as well as a variety of CYP2 P12Y19 inhibitors, 2B3A inhibitors that target platelets. So there are really multi-pronged targets that we can use nowadays for the anticoagulation cascade. It's actually surprising that patients don't bleed as much as they don't. So what's the determinant of successful antithrombotic therapy? Really is how hard you want to drive the antithrombotic therapy, and predominantly is based on the presentation mode, especially acute coronary syndrome. But you do need to start thinking of de-escalation. And the de-escalation or the bleeding risk assessment is predominantly the level of comorbidities and demographic that determine the bleeding risk. So it's always a tug of war between bleeding and anti-ischemic risk assessments. So what are the factors that increase risk of bleeding? We know that age, low body weight, CKD, prior history of bleeding, abnormal liver organ function, excessive alcohol intake, concomitant steroidal NSAID long-term use are all factors that increase bleeding. We do recognize them easily. The factors that increase ischemic risk is even clearer to recognize. Some form of diabetes, current smoking, CKD, prior acute coronary syndrome, stent thrombosis, acute coronary syndromes, multivessel disease, implantation of multiple stents in vulnerable locations, all ischemic risk predominance. So, but the confusion comes for a lot of folks is when we say it's ischemic risk factors, people confuse ischemic risk factors for bleeding risk factors and bleeding risk factors for ischemic risk factors because commonly there's an overlap. But what's not so commonly recognized is that the overlap is not one-for-one. The bleeding risk factors commonly come under the subset of ischemic risk factors. And what we do not want to do is firstly say that high bleeding risk is equivalent to high ischemic risk. Is not the same. And likewise, high ischemic risk is not necessarily equivalent to high bleeding risk. And if you do shorten your antithrombotic, antiplatelet effects early, the patient will suffer the risk of ischemic risk. But if you do unnecessarily prolong in the high bleeding risk patient, the antithrombotic anticoagulant use, then they're subject to catastrophic bleeding that can cause morbidity and significant mortality. So the scope today, I just want to quickly set the stage for defining bleeding risk. What does the major guideline tell us? What are the strategies to reduce bleeding without excessively exposing patient to increased ischemic risk? So what are the high ischemic risks? I think in a lot of these trials like COMPASS, DAP, Global Leaders, TIMIS, Twilight, or Pegasus, the ischemic risk factors are pretty well known. Age, CKD, type 2 diabetes, prior history of vascularization, or MI, or some form of peripheral arterial disease, which is always in there. In Asia, there are some differences. Maybe in some groups of Asian countries, age is higher, CKD, diabetes prevalence is higher, recurrent MI incidence is higher, particularly in India. The prevalence of multivessel disease may be less, and the prevalence of peripheral arterial disease may be less in Asia compared to the Western population. In APSC consensus, we use a CVD algorithm to define ischemic risk. C stands for prior coronary event, high-risk coronary anatomy, documented multivessel disease, whether through CT or CAP. V for established cerebral vascular disease, established peripheral arterial disease. D for any form of disease like diabetes on treatment, regardless of duration. eGFR less than 60 or some form of albuminuria, or heart failure due to coronary artery disease. For bleeding risk, in the stent bleeding risk truncation, depth truncation trials, a lot of the factors are quite common across this series of trials, like advanced age, concurrent OAC use, baseline anemia, thrombocytopenia, previous GI or intracranial bleed, hospitalization for bleeding, or end organ dysfunction. But you see in all these trials, a lot of the trials are openly represented in that subgroup of advanced age with use of anticoagulants at the same time. In the risk scoring calculators like REACH, Dutch AS, SAW, DEP 41, Paris 38, Precise DEP 32 trials, firstly, a lot of the trials' bleeding risk criteria are all over the place. The proportion of true high bleeding risk patients are at best 25% of the cohort. And lastly, the AUC adjudication for this group of patients is less than 0.7. So they are not very well correlated with bleeding. And more importantly, they are not validated in our Asian population. Be that as may, the ARC Bleeding Risk Consortium is quite well recognized and endorsed. Is defining a high bleeding risk as a buck 3 or 5 bleeding risk or more than 4%, or 1 year bleeding risk intracranially or more than 1%. And this is arbitrary, but this is defined high bleeding risk criteria. And if they meet 1 major or 2 minor out of this 20 major, 20 minor criteria that we will go through. In the APSC consensus, we form a simpler algorithm, just the ABO algorithm, to highlight to folks there are some cases that you need to think of high bleeding risk. A for age or frail above 75, or advanced age above 85, or minimum life expectancy. This age cannot be by itself, it needs to combine with either B or O. B, a spontaneous intracranial bleed before, or some form of recurrent GI bleed that cannot be correctable, or hemoglobin less than 9. O for organ dysfunction like end-stage renal failure requiring dialysis, liver dysfunction with liver cirrhosis, bone marrow failure or thrombocytopenia less than 50,000, or prior stroke in the last 6 months. And the other part about bleeding is that the bleeding risk definition and the risk of bleeding, there are 4 major bleeding risk definitions: ISTH, TIMI major, Gasto, Bach bleeding risk, but they are not the same actually. And you can see that the Bach 3 or 5 favored by the ARC criteria is quite significant. Bach 5 of fatal bleeding, Bach 3 or some form of intracranial bleed in 3C, as well as hemoglobin drop of more than 5. In the ISTH major, it combines every one of this, including a fatal bleed. So if you look at the studies, like in this case, the Engage AF TIMI 48 trial, if you classify bleeding into different categories, the percentage of severe versus minor bleed changes. So I think in most bleeding criteria is either the Bach bleeding criteria nowadays or the ISTH bleeding criteria. In the APSC consensus 2020, when you look at it, some of the guidance given, for example, to mitigate bleeding risk is to use some of imaging guidance while doing PCI, to use a 3rd generation drug-eluting stents. Bleeding risk and thrombotic risk should be assessed, but we don't endorse any specific form of risk calculator because it is not proven in Asians. Gender alone should not be considered when assessing bleeding or ischemic risk calculators. So if you look at this, ESC in 2020 came out with some guidance on how to mitigate bleeding risk. For example, before ACS, if your early invasive approach is being used, you do not need to load the P2Y12 inhibitor. 2B3A use could only be considered in bailout situation. And this outcome was predominantly driven from the ISA REACT 5 study. The ARC HBR bleeding risk criteria is also officially endorsed by the ESC in 2020. And these are some of the PCI risk mitigators, for example, appropriately dose adjusting by body weight, anticoagulation, taking into account renal function, default radial approach, default PPI use in cases where it's deemed to be high risk of bleeding. In patients on oral anticoagulation, PCI is performed without interruption of VKA or NOAC, and patients on VKA don't further use unfractionated hairpin if the INR is already more than 2.5. In patients with NOAC, regardless of timing, use a lower dose unfractionated hairpin of between 50 to 60 units per kilogram body weight. Consider aspirin use, but do not consider pre-treatment of P2Y12 inhibitor and 2B3A inhibitors only for bailout. And some of the other strategies like shortened depth can only be considered either dropping aspirin or P2Y12 inhibitors after 3 months, de-escalation of third generation to clopidogrel with reloading, bleeding versus ischemic risk assessment upfront before any procedures, and between 3 to 6 months, you can consider this truncation for patients. A point of care testing platelet function of CYP2C19 genotyping can be considered to further refine your 2B3A use. In the ESC guidelines, they also talked about in patients with AF and the requirement for stents, you can consider a triple therapy of just up to a week and then stopping after based on ischemic and bleeding risk assessment. In the ACS and STEMI subgroup, the main grounds is to assess bleeding risk. If the bleeding risk is deemed to be very high, consider aspirin clopidogrel approach and shorten to 1 month. If the bleeding risk is just high, the aspirin clopidogrel can be lengthened and then subsequently just aspirin alone. If the bleeding risk is very high, then it's not aspirin but in preference to clopidogrel. If the bleeding risk is low, there's a lot of choices out there for a higher ischemic risk patient. The aspirin can be combined with ticagrelor with 3 months in the 12-light regime or 12-light ticagrelor monotherapy after that, or aspirin, prasugrel, aspirin, ticagrelor, aspirin, clopidogrel up to 12 months, and extended DAPT if warranted, or dual pathway inhibition as indicated. Some other strategies include the FIRE trial, which showed that rivaroxaban monotherapy was non-inferior to combination therapy with an antiplatelet single agent with respect to bleeding risk, superiority, as well as reduction of ischemic events. So you can use just NOAC alone for stable CAD. There's also a strategy for acute PCI to consider a CYP2C19 genotype guided strategy to use aspirin clopidogrel in compared to a third generation P2Y12 inhibitor. At 12 months, is shown to have same thrombotic event but less incidence of bleeding. So the APSC consensus statement advocate using the algorithm of CVD to look at ischemic risk assessment and ABO algorithm to look at the bleeding risk guidance to come up with this flow chart whenever you transit from a position of DAPT or considering long-term management for CCS and you are dropping or considering dropping or extending, think about the CVD risk first. If they have any of the CVD risk factors, for example, you have a CKD patients who's diabetic, who's had multi-vessel stenting, then by all means, this is a high risk CVD risk. If they're none of the above, or CVD risk, they are low risk, you can go to single antiplatelet. If they are high risk, then assess their ABO algorithm. If the ABO has, for example, concomitant the patient is end-stage renal failure, hemoglobin is actually baseline 8, then they are with high-risk excessive bleeding. Then consider early truncation to SAPT. If, for example, they do have high CVD risk factors, but no ABO markers of risk for bleeding, you can consider 3 options. 1, if they have complex PCI, consider DAPT extended pathway, extend out your DAPT regime. Or if they have prior multivessel disease, multivate disease, post-bypass, post-ACS, post-PCI, PAD, cerebrovascular disease, consider a dual pathway inhibition with aspirin, low-dose rivaroxaban 2.5 BD. If they have complex PCI and they have tolerated 3 months of aspirin ticagrelor without any major thrombotic or bleeding risk, then you can consider a trial regime or ticagrelor monotherapy. So with that, I'd like to thank my stakeholders for the APSC consensus statements, and thanks to the audience for allowing me to present this short communication. And I'll welcome any discussion and question. Thank you very much for your time.
Thank you, Jack. We will just go to the next talk and we'll have discussion in the end.